Really quick. Hello, welcome everyone. Welcome to session 1 of Oxygen Therapy and Critical Care case-based series with Dr. Rachael and Dr. Kano. We're so excited to launch today. Today we'll be talking about considerations for triage. So just a few housekeeping reminders before we get started. Our programming is based on a foundation of love and respect, so please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe place. We will be using the chat function for Q&A, which is at the bottom of your screen. So please send all questions through the chat box and feel free to introduce yourself there. Please turn on your video if you're able to, and position your webcam effectively to show your face if you're alone or to capture the whole group if you are with people. If you have any IT issues, please send a message through the chat and we will help to the best of our abilities. And this session is being recorded and your attendance is consent to be recorded. So thank you for that. And then finally, please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice social distancing. So with that, I will turn it over to our experts, Dr. Rachael, Dr. Kano. The floor is yours.
Okay, thank you so much. Let me see if I can, okay, thank you. Rachael, can you hear me?
Yes, I can hear you.
Okay, thank you. So welcome everyone to this session. And I would like to say a few words before we can start. That we'll be running a series of sessions, okay? And the sessions will be, one will be building on top of the other in terms of continuation and complexity. So we'll start with simple topics, and then it will build on, and we'll, in the next sessions, we'll be discussing other topics that are a continuation of the previous topics. And the complexity of these topics will be increasing as we go. So although it may seem to be, these first lectures may seem to be maybe easy to some of us, but they are important in order to build a common ground for the following lectures. And we'll provide a list of lectures that will be presented to you in the future sessions. Okay. These sessions will be carried will be presented to you every first Friday of the month, okay, at similar times, unless Dr. Rachael changes the times together with you, depending on your opinion, all right? So today we're going to talk about considerations for triage, and the presentation will start with a case as you can see it on your screens, okay? Also, the structure of the presentations is in such a way that we have objectives, like practice change objectives. If you can see down there on the orange box, we have practice change objectives. And after we scroll down from there, these objectives will be discussed in that area. As she's scrolling down, you can see that there are some explanations of these objectives. And after these objectives have been fully explained, then we'll have another orange box with different practice change objectives, which will also be explained until the end of the session, okay? And as we continue with the presentations, we'll be having some questions. So we'll have questions that we'll pose them to you, and you will write answers in the chat box. And we will review them right now as we go and try to see whether the answers are correct or wrong. And then at the end of 1 minute, so we'll give you 1 minute to give all these answers in the chat box. So please identify where the chat box is on this window where you're listening to us now, on this Zoom window where you're listening to us now. check where the chat box is. When we reach a question, we will read it out and you will write your answers there. We'll review the answers, and at the end of a minute, we will explain further what is the correct answer to that question. Okay, so that will be the mode of all the presentations. All right, now starting with this session, let me just read out this case here. So starting with the case at the top of the screen, a 57-year-old man presents with chills, weakness, and a dry cough, okay? And we are talking about considerations for triage. If you go down there to the orange box, we have practice change objectives. The first one is healthcare providers follow recommended PPE guidelines. So we want to make sure that the healthcare providers follow recommended PPE guidelines. And then healthcare providers are trained in safe don and doff sequences for PPE. And then patients with potentially contagious infections are isolated early. And then screening methods for SARS-CoV-2 are in place in our working environments, in our hospitals, in our settings. And then healthcare providers recognize and diagnose hypoxemia. And then the following is healthcare providers use pulse oximetry to appropriately triage hypoxic patients. And then the last one is healthcare providers prescribe non-invasive oxygen therapy using the most appropriate device available. Okay, Sarah, can you scroll down so that we, so those were the objective of this subsection of this session. And now coming back to our case, okay? So the chief complaint is that this is a 57-year-old man with chills, weakness, and dry cough. Now, based on this, there's a question here in the blue box. This is a patient in the emergency room, okay? How would you evaluate this patient further? So if you are in an emergency room and this patient came, 57-year-old man with chills, weakness, and cough, how would you evaluate this patient further? Kindly type your answers in the chat box, okay? And we'll give this 1 minute. And then we'll proceed with some explanation about it. Kindly type your answers. I can see. So you have a chat box on this Zoom window where you can type your answers, and then we'll review those answers together. There is Srilok Mal says, do complete physical examination. That is correct, and that's good. You can keep on writing your answers here on this chat box. There's Jos Mutuku says, check his vital signs, which is also correct. Check vital signs, that's correct. So people are texting, determine if respiratory distress is obvious, if increased work of breathing and measure SpO2, that's correct. That is examine patient and check vitals. Interrogate further on the symptoms, that's correct, Maxwell Sanger. Do pulse oximetry, that is correct. Okay, so check vital signs and further history, that's correct. Okay, so the minute is finished and we'll continue from here. So with this box, with this blue box, if you want to know, all the answers that you've given are correct, okay? But if you want to know how to proceed further with this patient, there is, so you click on that blue box and it will take you to to this page, okay, where you can read further about how to collect history and how to do physical exam and do investigations, supportive investigations that will help you to make definitive diagnosis for this particular patient. So all the answers were correct. You get a patient with symptoms, you collect history, you do physical exam, you order investigations, you have your diagnosis, and you start treatment. So in these presentations, and you all will have access to these presentations, okay? In these presentations, when you see a blue box, you click on it, and it will take you to a supportive document, okay? Where it will explain the answer to that question, all right? Great. So let's go back to our slides. So we'll not read all this document because we'll not have enough time for that, okay? Let's scroll down. Okay, so you decide to perform history and physical exam on this patient, all right? When interviewing the patient further about the history of his present illness, you discover that he has a 4-day history of chills, weakness, and dry cough, okay? His wife is a nurse at a hospital and tested positive for SARS-CoV-2 3 days ago, all right? His wife has a pulse oximeter at home and had the patient check his oxygen saturation. The oxygen saturation at home was 89%, okay? So his wife decided to bring him to the hospital at the emergency department. Now, the next question follows in the blue box, and it says, should you now be wearing a PPE? And we will give you, again, 1 minute, and we would like you to put your answers, which is, in this case, yes or no, in the chat box, please. Everybody's saying yes. Christine Jeru says yes. Jackson Nyangara says yes. Teresia Njoroge says yes. Everybody's saying yes. Okay, we still have a minute. Okay, Zelifa Mwangi says yes. Muslim Abdullah. Emily Joy Meriti says yes. It looks like everyone has said yes. So let's go back to the chat. Joseph Tiati, Maingi Abraham Kiriuka. Let's go back to the slides. Okay, so everybody has said yes, but so when you will have access to these, if not already, all of you will have access to this material if you want to review and go through it again, okay? So when you're going through this material independently, maybe over this weekend, when you click on this blue box, can you click for us, Sarah? When you click there, like Sarah is clicking, it will take you to this material that will explain to you about personal protective. Can you scroll up? Let's see that. We want to see, can you scroll up? Yeah, you can see up here written personal protective equipment, okay? And this is a very good material. If you can scroll down, it comes from the Centers for Disease Control, PPE recommendations. And there's 2 videos, okay? One is demonstrating how to put on the protective equipment, and another one is describing how to take it off, okay? And this is from the WHO, World Health Organization, PPE guidelines, all right? So just for the sake of time, we may not go through, maybe let's just go through one video, Sarah. Can you click on
personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room.
You're on mute, Dr. Kano.
Thank you, Sarah. These slides provide you with these links where you can find these videos and you can watch them during when you have free time, okay? For the sake of time, we'll not watch the second video in hope that you will do that in your free time, okay? Another quick thing that I would like to mention here is that you can write any question that you have in the chat box and we will attend to it. So if you have any question as we go, please just type it in the chat box and we'll attend to it. I can see we have about 56 participants. That is a very good attendance. And I will hand over now to Dr. Rachael, who will take us through the next practice change action items. Thank you.
Thank
Which
you,
are
Dr.
in the orange box below.
Okay. Good evening, everyone. So I'll take off from where he's left. So the next thing is we want to practice change action items. So in this point, we want to create, our objective is to create training sessions for all providers in safe PPE donning and doffing sequences, print PPE infographics and display in relevant patient care areas, place PPE checklists in the COVID patient's room. So our next question will be, how would you triage and isolate this patient that you suspect to be having COVID-19? How would you be able to triage, and what would be your plan of action as you prepare to manage the patient in a facility? So I'll give 1 minute so that you can write your answers on the chat box, and then we can go through it. I think the chat box is open. You can all write and say how you'd be able to triage. It's the same patient that we're talking about, the 57-year-old who the wife is a nurse and was also when the nurse was COVID positive. So it's this patient, it's the same patient that we are taking over from. So how would you triage this patient? People are silent.
Okay, probably answers to this question are a little long.
Yeah, there's someone who says patient has to be isolated.
Yes, go ahead, Dr. Rachael.
Sorry, yes. Someone says patient has to be isolated. There's another one who says give the patient a face mask if he doesn't have, and take him to a well-ventilated room. That's correct. Take him to a designated isolation room. That's from Damaris. Yes. Isolate the patient and provide a mask. Yes, those are all correct answers. So in a patient who you're suspecting has COVID, the triage has to be done very well. There's something else. Give a mask to the patient, place the patient in a well-ventilated room. Yes, all the answers you're all writing are correct, and that help in isolating and triaging this patient. So the patients have to be isolated according to to priority and also the presentation of the illness, but you also have to remember that you're suspecting COVID. So it's a patient who you'll not want to manage with the rest of the other patients that you have in the acute and emergency department. Teresia says, any history of fever, cough, difficulty in breathing, sore throat, history of contact with someone with COVID, then isolate if yes to any of the above. That's true. Adonis says, have a designated isolation room and have an N95 for the patient. So we'll close that chat box, and all your answers were correct. So you need to have standard operating procedures when you're triaging a patient who has suspected COVID-19. And this helps in the risk of transmitting to the rest of the patients or the health workers. So a triage procedure whereby you have the hospital is aware of the patient who's coming in. So the health workers have been trained and they've been taught about how to triage, whereby there's even they have protective personal equipment. There are areas for washing hands, hand washing areas, and there are areas for even doing the vital signs and checking out how the patient is. So this is the document, this is the resource where you can get all the things that you'd want to know or you'd add on to the triage of this patient. So you have the background of how the patient is presenting, and then you classify it, and then you have the patient put in the priority areas. So isolating these patients is very, very important to avoid transmission of the COVID-19. Thank you, Sarah. Maybe you could go down. So in your free time, you can also get this resource as well. It's available in the platform. So you'll have a look at it and just add on to what I have said. But having standard operating procedures is very important when you're dealing with patients who have COVID-19. The next question, how will you screen this patient for SARS-CoV-2? What are the other presenting symptoms of SARS-CoV-2 infection? Can give 1 minute for this. Anybody? How will you screen this patient for SARS? Okay, in the sake of time, I think Sarah, you can click. But someone is saying other symptoms include loss of taste and smell, screen using a swab. There's the oropharyngeal, nasopharyngeal swab. That's correct. That is how you screen them. Anyone else? Okay, we need to know how to screen these patients is by having an idea of the symptoms of the patient. So initially when during the first phase of COVID-19, what happened, the symptoms were more of respiratory, but now the trend is changing. So initially the patients were presenting with cough, shortness of breath, and difficulty in breathing. Others had fevers above 40, there were chills. Some complained of muscle and body aches, there was vomiting and diarrhea, and even new loss of taste and smell. So asking all those symptoms and finding out if the patient has any of those symptoms would help to identify or have a differential diagnosis of whether they really have the COVID-19 or not. But it's also becoming very non-specific, where patients are also not presenting with fevers and chills and cough. They come with different symptoms. They could even come with signs of blood clots. So we just need to have an idea and even be open that it could be COVID-19. There's someone who says presentation against the case definition, also having a high index of suspicion. Yes, if there's a history of travel, if there's a history of contact with someone with COVID-19, have a high index of suspicion. If the person comes from a highly densely populated area, like in the slums, or works in a highly densely populated region, that one you should also have a high index of suspicion. Samani says history, blood tests, including PCR, other symptoms like taste, smell, gastrointestinal, chest pain. Yeah, that's correct. Okay, thank you, everyone. Sarah, you could go back.
Okay, so thank you, Dr. Rachael, for such a well elaborated section of this section, and I will take over and cover this following practice change action items. So I will read them out to you. The first one is establish screening stations outside the facility. Okay, so we're going to take a look at that. And then identify screening personnel and questions. So I'm reading them out to you. Number 3 is use a screening checklist. Number 4, screen everyone, including workers and employees. Number 5, use telephone appointments and algorithm for triage when possible. And then number 6, limit entrance points to facility. Number 7, post visual alerts at entrance points. Number 8, triage high risk and symptomatic patients to areas of isolation. Number 9, provide hand washing supplies and ensure face coverings. And the last one is ensure waiting areas are well ventilated and seats are 6 feet, which is about 2 meters apart. Okay. Now, can we scroll a little bit up? The following material will be describing these action change points. So we have a case update here. The patient denies fever, okay, from the history that you are collecting. Patient denies fever, shortness of breath at rest, headaches, loss of taste, and loss of smell, okay? He is talking in full sentences, but states he becomes short of breath with moving and eating, okay? He has been less active and is mostly staying in bed or on a couch, all right? So a nurse obtains the first set of vital signs. You see, we are following all the things that everybody had pointed out earlier on about how to approach this case. So this is the set of vital signs. Heart rate is 95 beats per minute. Blood pressure is 95/52 millimeters of mercury. Respiratory rate is 24 breaths per minute. SpO2, which is oxygen saturation in peripheral blood, is 89%. And temperature is 37.5 degrees Celsius. Now, we go to the blue box. Sarah, if you can just leave it the way it is so that they can correlate the two. The first blue box, there's a question there that says, what is hypoxemia? What is hypoxia? And what is the difference? So if we can just type our answers in the chat box, please, 1 minute, and then we'll discuss the answers. What is hypoxemia? What is hypoxia? And what is the difference? Remember, this lecture is meant to find a common ground, a common background from which we can build our following sessions so that we're all on the same page. So Neil Summer says hypoxemia is low concentration of oxygen in blood, which is correct. Sarah Romage says, okay, so they're coming a bit faster now. Oxygen level below 94%, okay. Hypoxia, low concentration of oxygen in tissues, that is correct. Jeff Segon, hypoxia, oxygen saturation of less than 90. So we're going to discuss about these things, about the cutoff saturations, okay, for different age groups, for different pathologies, okay, for pregnant women, we will see they all have different cutoff saturations. We will see these things in the following lectures, if not in this one later on. Okay, we'll see the cutoff saturation for patients with stroke, patients who have undergone open heart surgeries, etc., etc. Okay, Damaris Zakayo, hypoxemia is low oxygen in blood, while hypoxia is low concentration to the tissues. Okay, so 1 minute is gone, and we can probably now, Sarah, if you can click on this. So you see, Sarah is gonna, again, click on this blue box, and it will take us to this document that will explain about hypoxia and hypoxemia. And I'm sure all of you know about these things. So we may, if you can play that, Sarah.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism. Lack of oxygen leads to cell death, tissue death, and organ dysfunction. The rate at which oxygen is removed from the blood and used by the cells and tissues is known as oxygen consumption. Oxygen in the blood can be detected a number of ways. The majority of oxygen is bound to hemoglobin. This is known as oxyhemoglobin.
the saturation of hemoglobin can be detected directly
Okay.
using real blood gas analysis.
Sarah, maybe we can stop this because it's a bit long. And let's go back to the slides. So correctly, as it has been explained by you guys here in the chat box, hypoxemia, when you see emia, it means in the blood. So we have less oxygen content in the blood, in the hemoglobins, okay? And when you see hypoxia, it means in the tissues. So those are the two differences, okay? And we all know that oxygen is carried by binding on hemoglobin and transported in blood to the tissues where it is offloaded to the tissues. If you want to learn more about this, or if you have questions, you can post them here. And if you want to learn more, then later on, you can click on the blue box and finish the video that we were listening just a minute ago. And I can see Sarah is sharing the links to all these questions here in the chat box as well. This presentation is recorded and you will have a chance to listen to it again later on if you have time for that. So we go to the next question, which is in the next blue box here. And it says, what are the common causes of hypoxemia? So please, again, we give ourselves 1 minute here. I'm timing that 1 minute, and then please type your answers in the chat box, and then we discuss them after 1 minute. What are the common causes of hypoxemia? What do you think are the common causes of hypoxemia? Respiratory obstruction. Okay. Ventilation perfusion mismatch. That's correct. Anemia, respiratory acidosis. Okay. What are the common causes of hypoxemia? So low oxygen content in blood. ARDS, anemia, cold, asthma, COPD. Okay, so 1 minute is gone, and pneumonia, pulmonary edema, anemia, VQ mismatch, shunting, hypovolemia, high altitude. Okay, so I think Damaris Zakayo has given like a summary of all of them here, and it is correct. So you can have hypoxemia, that is low oxygen content in blood, because probably the air you're breathing has less oxygen, okay? If the air you're breathing has less oxygen, then you may develop hypoxemia, and that will be called hypoxic hypoxemia, okay? Or you can have normal air, you're breathing air with normal oxygen or even with increased oxygen, but you may have problems in the lungs, okay? So maybe you have pulmonary edema, okay? And there is impaired gaseous exchange at the alveolar level, and therefore that oxygen will not make its way to blood, all right? Or you may have bad hemoglobin, so red blood cells, which are not picking up oxygen that has been sent to blood successfully. And so, for example, when you have carbon monoxide toxicity, you will not have effective oxygen uptake from the lungs because all the binding sites are being occupied by carbon monoxide. So these will be the most common causes of hypoxemia. Can you click on this, Sarah, so that we can take a look at. All right, so there's another video here that will explain that, I think.
In addition to diagnosing hypoxemia, it is also important for healthcare providers to recognize the common causes of hypoxemia in neonates, children, and adults. Hypoxemia is defined by low levels of oxygen in the blood and is detected using arterial blood gas analysis or pulse oximetry. Pulse oximetry is more widely available, but arterial blood gas analysis is more accurate when available. The exact level of oxygen saturation that defines hypoxemia is not clearly defined, as the level at which tissue hypoxia occurs is not known. However, most clinicians agree that an SpO2 less than 90% by pulse oximetry qualifies as hypoxemia. A hypoxemia diagnosis can be made using arterial blood gas analysis, but if ABGs are not available, a pulse oximetry unit can also be used. In the instance where neither tool is available, bedside providers must use clinical signs to guide administration and titration of oxygen therapies. Common causes of hypoxemia in neonates include, but are not limited to, birth asphyxia, respiratory distress syndrome, pneumonia, sepsis, congenital heart disease, meconium aspiration syndrome, and apnea. Common causes of hypoxemia in children include, but are not limited to, acute lower respiratory infections such as pneumonia or bronchiolitis, asthma, meningitis, sepsis, congenital heart disease, perioperative complications, malaria, and trauma. Finally, common causes of hypoxemia in adults include, but are not limited to, chronic obstructive pulmonary disease, asthma, pneumonia, sepsis, trauma, congestive heart failure, pulmonary embolus, and perioperative complications.
Okay, Sarah, thank you. We can stop here and go back to the slides. All right, just scroll down, scroll again. So we have this other blue box here, and in it there is a question which says, is this 57-year-old male patient hypoxemic? Okay, so we see that he has a heart rate of 95 and a saturation of 89 and blood pressure of 95/52. Please put your answers on the chat box. Let us know what you think, whether this patient is hypoxemic or not. Okay, Maureen says no. Abbas says yes. Teresia, yes. Damaris, yes. Neil, yes. Jeff Sergon, yes. John Machayo, yes. Joyce Matuku, yes. So majority say that this patient is hypoxemic. All right, which is true because with a saturation of 89, this patient is hypoxemic because hypoxemia is any saturation below 90, as we shall see later on. We'll discuss about this later. Okay. If we can click on that box just quickly, Sarah, and then we go back. I hope. So guys, you can always click on this box at your own time later on, and you'll get to see the answers here. Okay, so this is the material you're gonna get when you click on that box, okay? I'll just close that and let's go to the next practice change items where Dr. Rachael is gonna take us through. Dr. Rachael, are you here?
Thank you, Dr. Kaino. I'm here. Thank you for the informative session. So we're going to go to the next one, and here the practice change actions are: download and print the oxygen wall chart, download and print the Lifebox Triage tool, post wall chart and Triage tool in patient care areas, that is in the emergency unit, ward, and ICU. Assign an equipment manager to process all contaminated reused items. So if you're in a facility that is receiving patients during this period, you should take this upon you to at least download all these Triage tools to ease management of patients. So in this same patient, you recognize right away that this patient is hypoxic. SpO2 is less than 90 on room air. While you continue your interview and physical exam, you decide to administer oxygen therapy. So you are training a nursing student. He asks, how much oxygen is being delivered to the patient? Why did you choose that oxygen delivery device? So the next question will be, maybe Sarah, you can go down. Which oxygen device will you use? What flow, that's in liters per minute, of oxygen will you start? What fraction of inspired oxygen can be delivered with each oxygen delivery device? Can give 1 minute for people to respond to that question. In this question, we want to see if we have the knowledge of the various oxygen devices that are available, and with those oxygen devices, what is the flow rate that is adequate for them? And when you put the flow rate, what is the fraction of inspired oxygen that you get, depending on the oxygen device that you decide to use? So it helps us to have a knowledge and a background of when to use nasal prongs or when to use face masks, and at least have an idea of what happens. So I think there are responses. Teresia says nasal prongs. Marina says, I will use nasal prongs at 3 liters per minute. That is correct. Nasal catheters to deliver low flow oxygen, maximum 5 liters per minute. Joanne says nasal prongs 2 to 4 liters per minute. Neil Summer says also nasal prongs at 4 liters per minute. Oxygen via nasal prongs 2 to 4 liters per minute, delivery of 30 to 40% oxygen. That's correct. Anyone else? Non-rebreather mask, that's by Abbas, which he says at 2 to 4 liters per minute. So I think we can go to the chat box. Sarah, you can click and we see there are various oxygen delivery devices, and all those oxygen delivery devices give oxygen at different flow rates and different inspired fraction of inspired oxygen. So for instance, you see the nasal prongs, you want to, sorry about that. Yes, nasal prongs, you want to give a flow rate of 1 to 6 liters per minute. And with that flow rate, you're going to achieve a fraction of inspired oxygen of 28 to 40%. Then there's a nasal catheter. The nasal catheter, you can use it in infants or children. The nasopharyngeal catheter, here you want a flow rate of 1 to 2 liters, and you'll get oxygen, fraction of inspired oxygen at 45 to 60% of oxygen when you use the nasopharyngeal catheter. Then when you just want to use the face mask without the non-rebreather, you'll set it at a flow rate of 6 to 10, and the inspired fraction of oxygen that you'll get is 44 to 60%. Then you have the one that has a reservoir bag, the non-rebreather, you'll set it at 10 to 15 liters. And the oxygen, fraction of inspired oxygen is usually high. You can even get up to 95, so 60 to 95%. Then you have the Venturi mask, which is usually differently color-coded. And this one, you want to set a rate of 4 to 15 liters per minute, and you'll get a fraction of inspired oxygen from 24% to 60%. So whatever oxygen device that you opt to use, know that, have an idea of what you want to achieve, the fraction of inspired oxygen you want to achieve, have a background of how the patient was. So like for this one, the patient, the saturations were less than 90. So in a patient who's less than 90, you might want to first try the nasal prongs at up to 5 liters and see how the response will be, and at least you'll get saturations above 90. There's also the head box, which is an incubator tent. Well, it's not really recommended by WHO because, as you can see, there's a lot of wastage of oxygen to the surrounding, and it's not conducive and it's not recommended. So this is not really used. We use all the other devices that I have mentioned above. Sarah, you could go back. So in our setup, being a resource-restrained country, we have very limited equipment. Are there any guidelines of reusing disposable equipment? I know most of us come from facilities whereby we don't have the option of single use. So what you can maybe tell us what you usually do in your facility. You can write it in the chat box. Do you have any guidelines? And if you do, what are the guidelines that you use as a facility in reusing the disposable equipment? I can give 1 minute to that as I wait for you to respond. Anyone who wants to comment about their facility? Nobody wants to comment? Okay. Abbas says Hexania solution. Anyone else? We reuse masks and prongs, but discard the HME. Yes, that's true. We have no options. That's Jackson. We use what is available. Sometimes it's tricky, and we have nasal prongs. Anyone else who has another input? So we can have a look at what the guidelines are that are recommended by WHO. Samani says we sterilize the equipment. Okay. Joseph says mostly face mask. Who else? There's another comment that I have seen. Dennis says sterilize, disinfect. Not sure we've allowed any specific guidelines. So I also don't think that there are any guidelines that are available in most facilities, because we just usually put them in soapy water. Then after that, you put them in Sidex, and then rinse, and it's ready to use. So the WHO guidelines. Sarah, could you project the WHO guidelines? Not this one. So there's a whole comprehensive document on how to decontaminate and reprocessing of medical devices, which is available in the resource facility, and it will be available in this website, which you can be able to read during your free time. So it's a whole document on how to go about the sterilization and disinfection of the equipment, because unfortunately we do not have the single use in our setup. So during your free time, I just wanted to show you that it's available. You can go through it, and then after that, you can come up with protocols to use in your various facilities that you work to prevent infections and to prevent infections from crossing over to other patients. So back to the question, to the presentation, Sarah. So the nursing student gets very inquisitive next year, where does the oxygen come from? Do we have enough for all the patients? So this is what we're going to discuss in the next session. So we just want you to have an idea of what we're going to discuss in the next section. As Dr. Kaino has said, we are building up slowly, stepwise, to get to now the detailed part of the critical care series of where you're going to do disease states and other further discussions concerning or around critical care. So for now, this is what we had for today. But at the end of the day, we want you to have the review practice change objectives, which are healthcare providers should follow recommended PPE guidelines. Healthcare providers are trained all in proper donning and doffing sequence of PPEs. Isolate patients with potentially contagious infections. Develop screening methods of SARS and COVID-2. Recognize and diagnose hypoxemia. Use a pulse oximetry to appropriately triage patients. Prescribe oxygen therapy using the most appropriate devices available. So these are the topics that we've talked about. So at least we have, I hope, kind of built into what we intend to achieve by the end of the 12 series that we'll have. And I'd like to thank everyone for attending. Over to Dr. Kaino.
Thank you, Dr. Rachael, for such a powerful, yet another powerful presentation there in subsection. You've led us well. So Sarah has stopped sharing the screen a little bit prematurely. We didn't finish with the very last part. Did you do that? Did you do that, Rachael? The last part. Sarah, can you share back the screen, please? Or maybe I can do it from here.
Sorry, the key topics review.
Yes, I think that is also important to do.
Oh, okay, sorry.
Yeah, maybe I can do that.
Yeah, you can do that.
Let me try to do it from here. We still have time, so I would ask you to ask as many questions as you would want. You can put your questions in the chat box here. So feel free to put your questions here and we will attend to these questions. So if you have any question, please just send it to us via these chat boxes. Okay, where am I? Okay. All right, so it's back here. Thank you, Sarah. So key topics review, we have IPC, PPE recommendations, and safe don-doff. Okay, screening for COVID-19, triage protocols, diagnosing hypoxemia, using pulse oximeter or clinically, or using the blood gas analysis. Sorry, for some reason I got disconnected, and I'm glad I'm back now. Rachel, can you hear me?
Yes, we can hear you.
Rachel, can you hear me? Yes. Sarah, can you hear me?
Yes, we can
Yes,
hear you.
Yes,
Okay,
I can
apologies.
hear you. Also got, I think I got.
Yeah, so these are the key topics that we were reviewing today, and we will do this for all the other sessions. We'll have topics that we'll review for every session, and we'll summarize them at the end. If you have any questions, please feel free to put them in the chat box below. The session was meant for 1.5 hours, and I think we have finished 1 hour so far. Also, if you have questions, if any questions arise after this presentation over the weekend or next week, you can send those questions either by email or on the WhatsApp chat box, okay? We have the WhatsApp group on your phones. You can text us and we'll get back to you with some answers or with some with links to the materials where you can read to understand more about the subject matter, okay? If there is no any questions, I think probably that's all that I had to share today. And like Rachael said, we are building up on the complexity of the topics, starting with simpler ones and going maybe to more interesting topics in the future. So we'll have ARDS, we'll have the basics of critical care medicine, the basics of intensive care medicine, and practice in ICU, and other topics later on. Rachael, if you have anything to say, I think I can hand over back to Sarah, who will close up the session.
All right, thank you, Dr. Kaino. I think I'd like to thank every participant who's made it to today's first session. Thank you for creating your time and making time for this session. We really appreciate. And we hope to build networks and improve on our critical care knowledge. That is the aim for these sessions, to at least build up on our knowledge that we have and see where we can improve and see where we can help our patients. And to Assist International, thank you as well for bringing this together. We really appreciate, and we look forward for further sessions. Thank you. Over to you, Sarah.
Thank you, Dr. Kaino and Dr. Rachael, for that very informative and excellent session. That was wonderful. So to wrap up, everything that you saw today from the Learning Resource Center to all of those extra resources are available for free. You just need to make an account on the LRC, and the link is here shared. So it's completely free. Make an account, you can access everything. Please join our WhatsApp group to stay connected and get updates on our next session. And then our next session is on July 2nd. We'll be talking about diagnosing hypoxemia and pulse oximetry. So please join us. And as Dr. Kaino said, if you have any questions, feel free to email us, echo@assistinternational.org, and we will answer the best of our ability or forward it on to Dr. Kaino and Dr. Rachael to address in the next session. So thank you all so much for joining us. We will see you in July. Have a good one, everyone.
Okay, good evening.
Thank you. Bye.
Thank you. Bye.